Hello, I'm Dr. Adam Brufsky. I am a professor of medicine at the University of Pittsburgh, and we're going to talk today about real-world use of real-world evidence in hormone receptor-positive metastatic breast cancer from the perspective of an oncologist. And with me today is Dr. Christopher Gallagher from MedStar Washington Hospital. Dr. Gallagher, how are you doing today?
I'm great. Thank you for having me.
Great. So, I guess the question is, we have these randomized clinical trials, and how do we really use them in everyday clinic decision making? I mean, do you use it to help you out?
Well, that's been what we've always had to use, but it's, we're limited by, our patient sitting in front of us wouldn't have qualified whether they have comorbidities or they're taking medications that would have excluded them, or their age, or something with their performance status. But the person in front of you is has metastatic breast cancer and is, you think, a candidate for a CDK4/6 inhibitor. And what can we learn outside of clinical trials? I think the value in real world data sets is, we're closing some of those gaps because we're seeing real world practice patterns and potentially seeing patients that have real world medical problems, like the patient sitting in front of us. And as I'll say an example, the P-Reality X study, where they compared palbociclib and an aromatase inhibitor to an aromatase inhibitor for metastatic breast cancer, where they looked at the Flatiron database and had almost 3,000 patients, when they did the evaluation of real world progression-free survival and overall survival. They was far exceeded, the aromatase inhibitor by itself with the use of palbociclib. And then when you look at some of the patients that were enrolled, they were older. They had a lot of visceral disease, and presumably more comorbidity. So I think, having that little bit of information to sort of complement what from the real randomized clinical trial helps inform your conversation, so you can sort of have a little more confidence in recommending something to your patient where they may not have been a good candidate for the randomized clinical trial.
Yeah, it really comes down to the patient in front of you. I mean, that's really what this is about. I think that it's a doc making the decision about the individual patient in front of them. And we use all sorts of data. I mean, I think that, again, in the days before randomized clinical trials, so say 40, 50 years ago, and going beyond that, even before that, I think that, we would see a series of patients, and we'd have, maybe we would read a textbook or two, potentially, to see if there are patients like it, or go to the literature, whatever literature there was, but really use our clinical experience to tell us what to do. I think we still do that. I think at the end of the day, it's our clinical experience, our own internal real-world data that we use, and I think we use a lot of what happens, both randomized clinical trials as well as the evidence that we've seen from real world evidence to kind of really integrate that all into our practice. I mean, we'll all go to ASCO, for example, and we'll see, wow, this is practice changing. You'll see a trial at the presidential session, at the plenary session, or one of the oral sessions in breast cancer, and you'll go, and everybody afterwards will go, this is a practice changing trial. You go, okay, I'm going to try it in my practice, and then you go well, wait a minute, the patients in my practice weren't quite like that. The BMI of my patients is like 35, where, BMI had to be under 30 or something like that. And I think that, or I have a lot of underserved African-American patients in my population, whereas, I think some of these clinical trials maybe only had 2 or 3% in that trial, or I have a lot of Asian patients in my population. How do these drugs work in an Asian population? And I think the nice thing about real world data is that it helps us. It kind of helps us in at least confirm our own experience. And it helps us when we try to use this in that individual patient. Maybe if we don't treat a lot of African-American patients, but we happen to have one in front of us right then, we at least have some data that gives us comfort as to what we can do at that point in time. And I think that's how I use it in my practice. I don't know if you have any thoughts on that.
No, I firmly agree. I take care of a lot of minority patients that, are not typically included in clinical trials, and I think seeing real world data is very helpful, because when only 2 or 3 or 4% of, a certain type of patient is represented in a trial and you have to care for them. I think real world data, especially when it looks at specific populations, is very reassuring to you as the physician and in having that conversation with the patient.
So again, I think at the end of the day, just to wrap everything up, it's the patient in front of you, and it's data that gives you comfort in treating that patient, whether it's a randomized clinical trial or real-world evidence. I think real-world evidence really fills out those gaps and gives us confidence. And so, thank you all for listening to us. And again, thank you very much, Dr. Gallagher, for participating.
Great. Thanks. It was great to be part of this, and I appreciate everyone listening as well.